Savannah Business Group is 30 years old. Started in 1982 when the 6 employers, CEOs got together and said, we're tired of health care increases. Of course, back then, it was $900 for admission. Hasn't gotten much better, but we've been able to do exactly what our mission is, and that's contain costs. The Business Coalition, there used to be a Georgia coalition. It went away. Augusta tried a coalition, it didn't work. Across the United States, business coalitions are practically in every state. There's also an organization called the Aligning Forces for Quality. There's about 15 of those in the United States, not in Savannah, not in Atlanta. There's also the Community Value Exchanges, which are run by HHS, and there's some collaboratives run by the CDC to make us a healthier generation. Not in Atlanta. Atlanta does have a problem. Columbus is organized, Macon's organized, Savannah's organized. So if you're in this area, you need to really get together with other employers of like mind and work together, because some of these issues cannot be addressed by you alone. And that's what Savannah has been able to do. Currently we have 21 employers, all self-funded. We represent about 53,000 covered lives. We're about 20% of the commercial market in Savannah. So we're able to make it in, and we have made it in. And Savannah loves being in the news. I used to show the park and the fountain and the port, but lately I've been having to show some of our more healthy activities like the Girl Scouts and the YMCAs, and Terra Fest and the Bridge Run, just to change a little bit, because we are definitely working on all these aspects in our community. The Safety Score website, you can look up your hospital. There are only 10 hospitals in Georgia that got an A. 3 of them are in Savannah. In the community, other than the public health, who else works on population health? Employers do. You have smoking cessation programs, you have immunization programs, you have chronic disease programs. You are influencing the health of your entire community. There's another new buzzword that's out in the community. It's called value-based benefit design. Sometimes it's called value-based insurance design. Once you figure out the quality and the costs and what people are going to react to it, and you figure out the outcome, you have to design a plan that supports your contractor. Many, many times we get it backwards. Too many times we buy for price and have no idea what the quality is. And be careful what you buy. Low cost is not always the best. So you have to do your homework. So there are 4 things that you have to do. You have to look at the cost. You have to look at the quality. You have to design a plan that supports it. And then you have to look at your community. It has been very successful, and this is some of the results. I gave this briefing to one of the boards of hospitals, and they were thrilled at this. They shouldn't be, because if every employer in town did this, what would happen to the hospitals? I mean, there's a reduction in inpatient days, a reduction in emergency room use. So this is where we have to address what's called payment reform. We have to learn how to pay our doctors different. We have to learn how to pay our hospitals different. Because if we keep paying fee-for-service, they're going to have no incentive to change. So we've got to change the dynamics. The city of Savannah has been able to drop their trend line 16% in the last 4 years by using these principles and being aggressive. They're collecting their data, they're looking at it. They have case management. Everybody has a case manager. Everybody. Depending on your condition, they may only call you once a year. Sometimes they call you every week. So there's 4 things an employer must do if you want to control the cost of your health care. First one is get the best price. When your broker brings you 6 things and says, here's the 6, you got to ask, why did you bring me these 6? Why did you bring me these 3? You got to look at the price. And remember, the lowest price is not always the best, and neither is the highest. Because you've got to look at the quality. Who is in this network? What doctors are in this network? What hospitals are in this network? And then you have to design a plan that supports your contracting. incentives, disincentives, and all the other things that go with health plan, and they have improved health in the community. So here they are. And it's a strategic plan. Healthcare costs are too big a part of your total budget to ignore it and not have a strategic plan in place to figure out what you're going to do with it over the next 5 or 10 years. The other issue is Medicare is one block with one payer. It is the largest single block payer of this whole pie. Medicaid is split up in about 50 different pieces. Employer-sponsored insurance, well, there's 70 of us in a room, 70 different slices. So Medicare is the biggest payer for the biggest block of people. That's a single entity, and they get to control a lot of the rules. Well, as we're doing all this stuff, along comes the Affordable Care Act. Been talking to other employers, been talking to other coalition groups. The big employers are going to continue working on the same things that I just talked about. Controlling cost, variation, working on wellness, working on their community, doing all the things they've been doing. They're not making any changes. So when you look at the Affordable Care Act, I like to divide it up by payer class. We have the uninsured, we have the Medicaid. We know what's going on there. That's all in the policy and political arena. We have Medicare. Medicare basically actually improved their benefits and expanded them. Medicare is actually working on quality. We have the exchanges that are going to be coming up. We have the fully funded, which are a huge amount of new rules for fully funded, and we have the self-funded. The Affordable Care Act was not designed to target self-funded employers. Self-funded employers are impacted, but not nearly as much as the fully funded are. So Medicare, this is out of Hospitals and Health Networks magazine, was called the 800-pound gorilla that has law on its side. We have to watch what Medicare does. And what's interesting is Medicare's been attending coalition meetings over the last 5 to 10 years. And we thought that it was very unusual for Medicare and HHS to be attending our coalition meetings. And during Secretary Leavitt and President Bush's time, they created this plan that they wanted Medicare to use. Then when the Affordable Care Act was introduced into Congress, Medicare walked in with a big old stack of papers and said, please put this into the bill. And they did. So now this is why they're doing quality reports. You can get quality reports right now on nursing homes and hospitals. They're also getting ready to start quality reports on physicians. Hospitals now are going to be rated and based on, well, we just got a readmission report from Medicare on all the hospitals. And based on that, hospitals are either going to see an increase or a decrease in the percentage they get for reimbursement. It's going to continue, and it's going to be more and more and more. So on the Affordable Care Act, how does it impact you as an employer? First, very clearly, there is no requirement for you to provide a health benefit. And that's a strategy, and there's many, many employers that do that. There's no requirement to cover dependents. Absolutely none. And a lot of consultants are telling their employers that the way to save costs is just drop all the dependents. And there's no requirement to cover your part-timers. However, if you have 50 or more employees, you may incur a penalty for not providing coverage. And there's 2 kinds of penalties. They're called A penalty and B penalty. Basically, that's because that's the subparagraph within the law. There's paragraph A and paragraph B. The first penalty is what is covered. And this is where we get into minimum essential coverage. And this penalty is $2,000 a year per full-time equivalent, minus 30. And when you are incurred this penalty, the penalty is on every single one of your employees. Penalty B is how much is covered. This is what's called minimum actuarial value. And it's an affordability test, which basically is around, it varies, but the rule you need to use is 9.5% of payroll. And that penalty is $3,000 a year for every full-time employee that gets the tax credit. And I want to expand on these just a minute. Minimum essential coverage. means that the plan that you pick has to provide certain services. If you do not provide these services, you will be penalized. There's what's called the Essential Services Package. It's a list of about 11 things. Georgia, every state, was told that they could select a template plan to use as their base Essential Services Package. Georgia selected Blue Cross Blue Shield Small Business PPO as their template. You also have to include all the women's preventative services. You have to include all the children's health services. You have to include all the immunization services that CDC lists as A and B. And you have to provide all the preventative medical services that are listed A and B by the U.S. Preventative Task Force. It's a lot of stuff. This is so, you know already that when you sit down and you do your plan design, you know that if you raise the copay $10, you know it's going to do this and you do that. Well, now you have this new rule you have to meet, and it's called the actuarial value. You also can have no pre-existing conditions. There's now limits on the age range. All the actuarial underwriting has changed. This is a huge impact on carriers. They also have to comply with what's called the medical loss ratio, where 80% of the premium now has to go to the cost of health care. They can only use 20% on administration. So if you're purchasing health care, this is a huge impact on you, because you, as the small business employer, are going to be held accountable for whether or not the plan is essential, provides all the essential services, but also if it's actuarially has value. If you're purchasing this product, you have no control over what's in the plan, and you have no control over what they have done with the premiums and the co-pays, but you are going to be held accountable for it. So when you sit down with your brokers and your agents, you need to make sure you have a qualified health plan. I can shout out one of them. And you need to very carefully structure your plan design to make sure that you have actuarial value. These are new tasks that you're going to have to do that you have not previously done. Anybody can purchase health care on the exchange. But not everybody gets the subsidy. So you can go to the exchange and request health care from the exchange, but it doesn't mean you're going to get the subsidy. There are exceptions. The first one is you can get a subsidy if your employer coverage is unaffordable. This is where that affordability comes in. You as an individual say, my employer's health care is too expensive. It's more than 9.5% of my premium, of my pay. It's unaffordable. I'm going to the exchange. Well, the first thing they do in the exchange is they look at your income, they look at what your employer's health care costs are, and they calculate out the affordability. Now, you as the employer have to use the 9.5% of your employee's pay as the rule. The law called the Cadillac tax comes into effect in 2018 for a rich plan. We have not yet gotten to the point where we can publicly report on providers. Part of that's because of the embargo on some of the data. We do have several medical homes in our communities. We are getting better coordination of medical services. We just renegotiated our contracts, and they do include transition of care and readmissions. We are still working on the use of national standards of care in our community. The standards of care are very clear. The doctors are the ones who wrote them. So it's, when you approach a physician and give him his data, it's an eye-awakening experience when they find out that they're not doing as well as they think they're doing. And we are working on improving health for our community. There's a lot to be done. It's like turning on a fire hose this morning. This is something Savannah Business Group has been working on for 30 years. When I get a new employer, sometimes it's hard for them to catch up. But that's okay. You can only do it one step at a time. It's part of your strategic plan, and you know what you're going to be doing, and you know how to get there.
So my name's Jamie Benton. I'm over HR for Racetrack Petroleum. It's here in the Southeast. And we have unique challenges because we're 6,500 employees in 13 different states. We're not all just the racetrack gas stations that you know here in the Atlanta area. We have racetrack gas stations in Atlanta, Orlando, Tampa, all through Miami, in Louisiana, and out in Dallas, Texas. But we also have a raceway division. If you go down 75 or the I-85 corridor, and it's in Tennessee, Alabama, that is an owner-operator division for us that we have employees for. We also have a trucking division. We actually have 27 different entities that roll up into what we call RPI. So I have one truck driver who lives in Virginia. I got 3 truck drivers that live in Arkansas. So I have a large office here with 700-800 people, but basically I have 370 offices around the Southeast with about 10 to 14 employees. So our health communication, health plans is very difficult. When I came to the racetrack, 8 to 10% year-over-year health growth from 2002 up until 2010, when we made a switch in 2011, which we'll talk about here in this, on this panel. And in 2011, we had a 12% reduction in our healthcare costs. Last year, in 2012, we had a 6% increase on our 2011, but we still are underneath what we spent on healthcare from 2010, and that's with over 500 more employees on the plan and over 1,200 more lives on the plan. So we've had some success, and we'll get into it, but that's kind of what racetrack is.
Good afternoon, or is it morning? Good morning. Yeah, I'm Vince Falcioni. I'm not a healthcare expert. I'm not an HR guy. I'm an operations guy, a manufacturing guy. And I mean, the bottom line, the reason I'm here, and the reason I'm so concerned about healthcare costs, because it impacts the bottom line. It impacts our employees, and that impacts us. We really believe that. If Procter & Gamble, we're the largest consumer products company in the world. We have 40 facilities across the United States, 50,000 employees. And our plans are really designed in Cincinnati, which is our headquarters. But we have opportunities here in Georgia that we don't necessarily have in other states. Our healthcare costs are much higher here in Georgia than the other states where we have facilities. And so, again, I'm very concerned, and we've been working healthcare costs for a long time. P&G, our philosophy is what's right for our people is right for our company, and vice versa. And doing the right stuff as far as wellness is good for our employees. It's good for our company. It's good for our employees' families, which is also good for our company. And it's good for the public, the community. So, again, doing the wellness stuff, which I think we're going to get into in more detail in the near future, in a couple minutes, is one of the most important things we can be about. Because it does impact the bottom line, it does impact productivity, it does impact our absentee rate, it impacts our disability rate, it impacts our safety performance, it impacts our overtime, and it impacts our morale. And all that stuff is real important to large manufacturing when it comes to taking care of the business, so we can give the consumer the best value that they can get with their product.
The healthcare industry is your friend. One of the challenges that we run into, I'm beginning to do some work with a lot of hospitals, and one of the problems is that the hospitals invariably recruit the very top business leaders in the community to sit on their boards, thereby neutralizing any dissent. Often the chambers are not willing to do anything on behalf of their rank and file members because their biggest members are the health plans and the hospitals. Business health coalitions across the country often take money from the drug and device companies and so are unwilling to do anything. So the industry has effectively divided and conquered. And I think that as a starting off point, one of the things to understand is the industry's divide and conquer strategy, and that the only way to make headway with this problem is for it not to be an HR and benefits problem. It has to be a C-suite issue with the involvement, particularly of the CFO. This is ultimately a finance issue from a business's perspective, and the various tools available to the business relate to policy and as well as tactics. In the hospitals that we're working with right now, there's an important dynamic that everybody should know about, which is that hospitals are in a box. They have had 40 years of this run of getting incredible reimbursement and making very good margins. And with the beginning of the recession in early 2008, procedural volumes began to plummet because people didn't have the disposable income to have the procedures that they were used to having. So that dropped. And then they're looking at a $30 billion a year hit under Medicare, under the new law. They're looking at the commercial health plans squeezing them as well. There are all kinds of other little irritations like Medicare penalizing them financially for too many readmissions and so on. So we've gone to hospitals and said, you know, the thing to do now, you know that the market is moving away from volume and toward value. The thing to do now is to begin to restructure how you manage the care process and to demonstrate to employers that if you can do, that if they send if they steer their patients to your health system, that their costs will be lower and their outcomes will be better. And so we'll work with you to make that happen. But it requires a real effort that is transparent, and it'll require you throwing your own employees into the pot to demonstrate the concept. That is something that should be available to everybody in this room, but it should require a covenant, and it should require you putting the hospital at some form of risk. So as a sort of an opening shot, that's an interesting place to begin.
I am not an HR, I work in HR, I'm over HR, but I am not an HR person. People who know me will tell you I'm the furthest thing from HR to be. I grew up, I went to school as a molecular cell biology major, and I went and coached college football. But my dad had his own company all the way up through. And the first thing you have to do when you own your own small business is you got to know what comes to the bottom line. And to not think that this is an expense to the bottom line, if you think you're doing something for the people, which yes, we have to worry about the people, but things for the people never get passed in the C-suites. You never go up to the board and say, I want to go put on this employee picnic because it's going to improve morale. It doesn't, you have to do those things. So at Racetrack, we talk in operations speak of how many stores can you build, how much a store costs. A store now that we're building costs $6.2 million. And if you're an HR person and you don't know the operations speak, you are behind the 8 ball in getting things approved. And so I can build how much of a store because you put it in their language. We were at sitting in a class last week that our accounting department just went through. Every $100, we're a $9 billion revenue company. They broke down a $100 bill. Every $100 that we make at the store, we only take 63 cents of that to the bank. So everything that we do now is how can I get that 63 cents to 64 cents? How can I take 64 to 65? How can I get that up to 70? And healthcare is a huge portion of that. So it's all about, yes, healthcare is a problem, we all know that, but how do you get it to an operationally sound position so that the C-suite understands it? They do not understand healthcare, they think healthcare is taboo. I can't talk about people's health. I had a doctor one time tell me many years ago, as a doctor, the only thing I can do is give them a 3-month prescription and they can come back to my office and I can yell at them for not taking it or they're too fat or too overweight. He goes, but as a company, you tell them basically what time they have to get up in the morning, what they can wear, what time they have to be in at work, where they have to sit, what they have to work on, what time they can do lunch. We basically tell them everything they can do during a day, except you need to be healthy, or you need to go to these doctors, or you must do this, you must do that. We thought healthcare is taboo, and it's not. And if you break it down to the C-suite, to the language they understand, you will get things approved much faster.
Yeah, I agree with some of the things that Jamie said. The reason we got involved in Albany is because our corporate headquarters said, what's going on down here with healthcare costs? Years and years ago. We have all these facilities, and why is your healthcare cost in Georgia what they are? And when your hierarchy from corporate calls down and asks you questions like that, you respond. Now at the plant level, I mean, when you're dealing with HR, or whether we're dealing with some of the nurses that we have on staff, there's a saying that we use, in God we trust, everybody else needs data, so show us the data. And the one thing that we know is that our healthcare costs are putting us at a competitive disadvantage compared to not only the other people that sell products like us, but even the sister plants that the Albany plant competes against within P&G that we're trying to always battle for volume. So it's important to manage this. It's part of base business. One thing I don't agree with what this gentleman said is that, with Procter & Gamble, our employees are our most valuable asset. And there are times where we do stuff because it's the right stuff. Again, we're a $90 billion corporation, okay? We had $16 billion in profit last year. But you got to take care of your people because they're the ones that either make you or break you, and that's important that we continue to do that. So when it gets back to healthcare, we implemented this risk-based premium stuff in 1993. We were the first plant in P&G to do this. And every employee every year, they go get some blood work done. And there's 6 areas that we measure them on, and if they're at risk, well, we help them work on it. If they're not at risk, then they get a $6 credit on their premium per month for each one of those 6 areas. So they could save $30 a month just by keeping their things in line. And we also offer that to the spouses and to the dependents. And that was just a starting point. When we started, it was like pulling blood. People didn't want to do this. Now, 98% of the people, we don't even have to remind them. They know how important it is. They know it's important to their life. They know it's important to their family. They know it's important to P&G Albany's competitiveness. And, when you're healthy and your kids see you working out, they see you eating the right way, it's not surprising that your kids eat healthy. They work out, and it's just part of what they do.
We find that many of our employer clients are utterly clueless about where the money's going. We will not work with a company that does not give us all their healthcare data. So we want the med-surg claims data. We want the PBM drug claims data. We want the biometric blood draw data and the HRA data. If they've got a disease management or a utilization management company that's working with them, we want their data. We want to know everything that we possibly can. And once you've got that data and you throw it into a pot, we have a predictive analytics tool that we're using. There are a number of different tools that are available out in the market, but anybody who's in this room should have access to one, either through a collaborative or you may be big enough yourself. You're talking about spending something less than $1 per employee per year to have access to a tool like this. And given that most companies are spending north of $7,500 per employee per year, this is a very small opportunity cost, and the potential for ROI is immense. So what you want to know is who's got chronic risk and who's got acute risk. 3% of your entire population in most groups is likely to have a major acute event over the course of the next year. You want to try to identify who those are. Now, you're not allowed to know under HIPAA. So you have to have someone who does that for you. You are allowed to know on the occupational health side. And to that point, our electronic health record is bifurcated so that the employer cannot know anything on the group health side, but they can know on the occ health side. When I go to jail, I'm going to go to jail for something a lot better than HIPAA, I can tell you that.
One thing that's important to the company is not to compare what we spend per employee in a certain location versus another location. So that's one thing that's very, very important. We want to know the data. We know the data as far as how many of our people are getting their blood work every year. We know what percent of our people are obese. You talk about our healthcare experts. They're on the main floor with our company's CEO in Cincinnati. The HR and healthcare expert meet with our CEO every Sunday. We talk about some of the stuff that's going on at his house every Sunday. For a large corporation, talk about, okay, what are we doing? So it's no different than how you're doing on your process reliability, or how you're doing on your efficiency, or how you're doing on a specific project. This is all about changing the culture. We need to create an environment in the workplace that makes it easy for employees to make healthy choices. And I'm always looking for data that demonstrates that. We spend money on the healthcare center. We have 3 nurses. We do stuff differently with our cafeteria. We have 2 on-site fitness centers. Why do we do that? We do that because we know that if we have it on-site, it increases the chances that our people are going to be working out, and it's going to help them in the long run, which is going to help our costs in the long run. So it's all tied into the business model. And again, understand our Procter & Gamble, we really get into data. I mean, I can tell you how many times the average Italian woman washes her hair a month, right? Or I can tell you when somebody's using Charmin, how many, whether they count the sheets or whether they wrap it around their hand before they eat. So we're always looking at data.
Is that a violation of HIPAA?
No, we have cameras installed.
That's another reason.
But the bottom line is the more data, the better. And, I won't look at the data if it's not useful to me, and I won't ask for it. I mean, give me what you have. The more data, the better it is for me to make a decision.
Well, there's two types of data. There's historical data and then future data, predictive data. Historical data you just give to get, right? This is what's happened. But where you have to get to is the predictive modeling of what you think is going to happen. So I think in West Florida, we have 3 chronic cases of diabetes going on. I need $50,000 to go do X, Y, Z that we're going to try to not have it happen, or whatever it could be. So it's the predictive modeling that you have to get into, and that's when you get to be a partner at the C-suite of, we have a problem here, let's go spend this money to get ahead of it and go do it, not always, oh, well, we missed these 3 heart attacks in West Florida and it cost us $200,000.
However, when P&G does this and does it, when they go to the hospitals in Albany and they explain this, now for the first time, the hospitals have pressure on them that they didn't have before. So he's exerted a market vector that has tremendous power to change the system that just hasn't been in the equation. That's what's ultimately necessary. That, as I see it, is the larger mission of this meeting.
Absolutely. In our corporate office that's 10 miles up the road, we had 75 people outside in the parking deck because it was raining yesterday doing boot camp. It has now become the culture of our corporate office to where people now talk about who's going to Zumba, who's doing this, who's doing that, and it has become our culture. I spend $20,000 a year in just having fruit on the tables out because 3 years ago I said, hey, just go buy some fruit, put it out, see if it does, and our CEO eats a banana and an orange every morning. And the people who used to have the vending machines don't like us anymore, we've gotten rid of them. So it's little things like that that you don't think makes it, but it's now our culture. It's our culture that people ask, hey, are you doing the boot camp, or are you going to do this? We now have 5Ks in every one of our market. We've done it on very little certain procedures that have cost us the most money going through the things. We're looking to do it more. We're looking to go into more. The type of plan you're on is based off of your biometric data, what your outcomes-based is, plan design for the next couple of years. We're going to that, but we're looking to do more of that.
We also agree with you. The design that we've settled on is that our clinics are voluntary. Nobody is required to use the clinics. You can always default to your doctor that's on the health plan. You'll pay whatever the copay is associated with that, and if you come to the clinic, it's free. However, even as seductive as free is, if you provide a lousy patient experience, people will not come back and they'll tell all their friends. So if you're trying to create an alternative option, which strikes me as redundant all over again, if you're trying to do that, you really want to work as hard as you can on a retail model that is as patient-friendly as you possibly can get.
Well, and being in the retail environment, you have to do it. You have to get it right the first time. Because if you have a patient walk into your facility and have a bad experience the first time, they're never coming back. So it's just like a customer walks in our store. We have to make that the best experience they've ever had in that store because they'll never come back if they don't.
They can help you out. There's this thing called their health coaching. We're a team of experts in your corner, registered dietitian, fitness professional, lifestyle coaches. They're a phone click away. And if you go through one of these programs, you get a $100 cash reward. If you have heart disease and you go through whatever the programs are, you get a $200 cash reward. If you take the Healthy Heart Person Wellness Advocacy Program, after you're done with it, it's a 6-week program, you get a $100 cash reward. So we're always offering these things to our employees and dependents just to continue to build that culture. I mean, it's not part of something that we do. We want you to be healthy. We want you to be here for a long time. We want you to be at work. We want you to be productive.
Well, that was the goal of employers like me, right? We started this 3-some-odd years ago in Sonny Perdue's office. The goal of this is to how do we all come together as employers so that we're not sitting up in our office saying, I wonder how the hell I can do this. Because there's someone else out there who's probably already done it, okay? And the thing is one of the first things we did at Racetrack was come up with a 1, 3, and 5-year plan, okay? You can't buy it all at one time. You have to pick where is my best opportunity to go do it. Is that plan design? Is that this? Is that that? What is it? And go focus in on that. And I will tell you, yes, bigger companies have resources to make it easier, but also bigger companies can be like the Titanic. And turning the Titanic sometimes takes a long time, but where small businesses can be more nimble, you also can have more control over your people because you know where they're going to be, you know how to get in touch with them. So you do have some advantages that we don't have. What we may have on capital, you have just on exposure to your people and stuff.
Thank you, Mary Eleanor. Again, thanks to the panelists. You guys have been very patient this morning. We appreciate it. We actually we've attempted to have a healthier lunch. So we've got lunch waiting for you out here. It's in the lobby. You'll see it. It's pretty obvious. But next door, the way you came in, a couple of